And if I can slideshow here. Okay, guys. We've done lots of stuff in general about the ECG. You guys have done brilliantly. So this session, we're going to start moving towards some of the more specifics related to the inherited conditions that that you guys are particularly interested in. And so we're going to focus on Brugada syndrome this week. So we're stepping it up a gear, if you like, to some specific pathologies. But let's first of all go through the homework from last week, or a fortnight ago. So a fortnight ago, we did a little bit about bundle branch blocks and pacing. We talked about how bundle branch blocks are shown as broad QRS complexes. And the way that you're going to tell the difference between a left bundle and a right bundle is, first of all, by looking at lead V1. In V1, a left has a big negative deflection. And it is positive in the lateral leads, so 1 AVL, V5, and V6. It may have some associated ST elevation in it. On the other hand, right bundle branch block in lead V1 has this RSR pattern, this bunny ears pattern, and in contrast, rather than being positive in the lateral leads, right bundle branch block will be the opposite, and it'll have an S wave in the lateral leads. Okay. We then looked a little bit about the sorts of patterns that you might get on an ECG associated with pacemakers. We talked about how you could have an atrial pacemaker, in which case you'll get this little spike occurring before a P wave, and then you'll have an intrinsically conducted QRS complex. So if the normal QRS complexes for that patient are narrow, then you'll have a narrow QRS complex. If that patient has a bundle branch block, then it'll look like that. On the other hand, if you've got a ventricular pacemaker lead in the right ventricle, if a right ventricular pacing lead will tend to lead to a left bundle branch block pattern. So you get this initial spike just before the QRS complex, and then you get a left bundle pattern. On the other hand, if you're pacing both chambers, you get a pacing spike before the P wave and before the QRS complex. Okay, so those are three common patterns that you'll see with pacemakers. You need to look out for these little spikes before the chamber of interest, and that's going to influence how you interpret the ECG. So let's have a look at the homework. So some of these were a little bit more challenging. So I gave you some hints in the top to give you some starting points. Okay, so let's bring this up here. All right, so who wants to go first?
I'll go first.
Great, go for it, Claude.
Left bundle branch block.
Excellent.
In V1, I've got negative QRS.
Brilliant.
QRS that's larger than 120. A bit of ST elevation.
Yep.
And positive QRS in 1 AVL, V5, V6.
Excellent, very good. So it's a typical left bundle branch block pattern. Yep. So we've got a bundle block there. What rhythm's going on? The second part of the question.
I didn't completely get that. What was meant by what rhythm?
Okay. So do you remember we did the lecture on rhythms about how you can?
Okay, so we're referring to the last classes. Okay. Let me take a look at this. Well, it seems regular.
It does, yeah.
And
yep, good start. Yep, so work through it systematically. Excellent. So it looks regular. Is it slow, fast, or at a normal rate?
Oh yes, okay. It's I would imagine it's slow.
Yeah. Okay. So what could you give me an estimate of the rate? Do you remember how we estimate the rate?
No, I've forgotten that.
Number of big squares. So I've got 1, 2, 3, 4, 5, 6, 7, 8 big squares in between QRS complexes. Can anyone give Claude a hand as to how you work out what the rate is? If we've got 8 big squares between QRS complexes, then the rate is approximately.
So I did, when I calculated the rate, I got between the QRSs, it's approximately 39 or 39 beats per minute.
Yeah, that's right. So we've got three. So we divide 300 by the number of big squares between QRS complexes, which works out as roughly 38. Okay, great. And the normal heart rate is between 60 and
100.
Yep. So this is slower than normal. Okay. So we're regular, we're slow. What's the next step in? So we're regular and slow. Is there any atrial activity? And hint, the P waves are marked.
So for that, what I did was, because there is atrial activity, I also got the rate for between when the atria are firing, and I got 75.
Okay, very good. So the atria are firing at, so we've got a different rate for the atria and the ventricles. Okay, so there are P waves, and these P waves are marked here. We've got 1, 2, 3, 4, 5, 6, 7. On we go. We've got the P waves here. Okay, so what's the relationship between the P waves and the QRS complexes? Is there a relationship?
It's a 2-to-1 second degree AV block.
Excellent. Boom. Well done, Anne. Very good. Excellent. So we've got second degree AV block, and it's 2-to-1. You're absolutely right. So you've got second degree AV block and a left bundle branch block, and those things. If you've got a high grade AV block, so second or third degree, then you'll often get evidence of conduction disease in other places as well. So the left bundle fits very nicely with that. Excellent. Well done. Well done, team. Great team effort interpreting that one. Next.
I can try this one. For this one, I got ventricular tachycardia with a possible first degree AV block. But I didn't see a bundle branch block.
Interesting. Okay, right. So that's okay. That's a good start. So you don't think there's a bundle branch block present, and you think this is ventricular tachycardia. Okay. Tell me why. Tell me what makes you think that.
Okay, so the reason I thought that there was no bundle branch block is because I don't see the pattern for the left bundle branch or the right bundle branch, in the sense that there's no bunny ears.
Interesting. What does everyone else think? Does everyone agree?
Well, I think there is a right bundle.
You think that's right bundle? So we've got one vote for no bundle branch, got one vote for right bundle. What does anyone else think?
I said no because there were no RSR prime waves.
Say again?
Me? Oh, I said no bundle branch block because I also didn't see any RSR prime waves.
Okay.
Yeah, same here. I said no bundle branch block.
Okay. I'm afraid I'm going to go with Claude. I think Claude's right here. So there is an RSR prime pattern. Okay, so you remember it can be present in V1 or V2, and it's not the easiest to see, but we do have an initial deflection that's positive, that then goes negative, that then goes positive again. So this is a right bundle branch block pattern. It's a little bit difficult to see in some of these complexes, but this is a right bundle branch block pattern, which fits with there being a deep S wave in the lateral leads here, V5, V6, lead 1, lead AVL. So deep S wave in the lateral leads, and there is, although it's a little bit difficult to see the first R wave, there's certainly a large broad R prime wave here. So there is a right bundle pattern. Okay, fine. But that doesn't mean that it's not VT. Sometimes VT can look like that as well. So why did, oh, sorry.
So you cut off there. What was the question?
Okay, so the next, so what made it that it was VT?
Oh, well, I thought it was, well, one, the rate was 150 beats per minute.
So it's fast.
So that tells me that it is tachycardia. And even though what I had assumed, instead of going that it's an RSR wave, I assumed it's the P waves kind of merging in with the QRS.
So do you think there are P waves?
Well, when I looked at it, since I didn't interpreted as an RSR wave. For example, if I'm looking at V2 as I'm looking at it, I was like, okay, maybe the P waves are merging in with the QRS, and thus that, the P waves are there, but they're just forming to a larger. But if I interpret it as an RSR, then I'm saying no, then they don't see P waves.
If I can paraphrase you, so before we jump to a diagnosis, if I can paraphrase you, it's pretty difficult to determine if there are any P waves there. Is that a reasonable, different way of expressing what you're saying? So what if we take a step back, it's fast, is it regular or irregular?
Irregular.
Irregular. Okay, I would agree. It's very irregular, isn't it? So if we just look at this first bit here, we've got this looks fairly steady. There's definitely a long RR interval there. A long R interval gets shorter, gets much shorter, gets even shorter, gets longer again, gets really a even bit longer still. So it's very irregular, isn't it? So what do you think the rhythm is to be if the ventricular response is irregular and we can't make out any P waves? What does that say to you?
Is it atrial fibrillation?
It is atrial fibrillation. 2 out of 2 for Anne. Very good. Okay, so this is atrial fibrillation with a rapid ventricular response and a right bundle branch block pattern. Okay, so these are getting harder every time, aren't they? You thought it was easier. You thought it was easier a few weeks ago, but these are getting trickier. But well done. Excellent. So atrial fibrillation with right bundle branch block. Next. Who's going to go for this one?
I can take it. So I thought that the QRS was greater than 3 small squares, so greater than 120. V1 is negative, and the lateral leads were positive with ST elevation in the leads with negative complexes. So I thought it was left bundle branch block.
Excellent, well done.
And the rhythm, so I thought it was the P wave was kind of merged with the T wave.
Brilliant, very good. Waves right at the end of the T waves here. Okay, yeah. Excellent. Okay, what's the relationship between the P waves and the QRS complexes?
It was 1-to-1, but there was a really long PR interval, so I thought it was first degree AV block.
Hang on, 100%. Very good. Sinus rhythm, first degree AV block, left bundle branch block. Absolutely perfect. Well done. Very good. Does that make sense to everyone?
Yeah.
Good. Very good. Next.
I'll try this one.
Yeah.
Um,
I'm going to tell you, this is the hardest of the lot. Okay. So if you get this one right, I'm going to be super impressed.
Okay, I said that there was left bundle branch morphology. There's ST elevation in V2, 3, 4, and 5. Or not.
Yeah, it's good. Keep going.
And then I said for the rhythm, second degree AV block type 2, the rate is about 48 to proc average and a left axis deviation. And then there's more. There's more. Ventricular pacing spikes are visible between some of the QRS, before some of the QRS complexes, but not all of them. And then some of the pacing spikes are not followed by QRS.
Okay. Okay. So do you think it's working?
No.
Okay, very good. Okay, I think that's excellent. So there's I think you've almost got that perfect. I'm really impressed. Well done. So you're absolutely right. So here we can see that we do have this left bundle pattern preceded by pacing spikes. So this is the pattern that you see with right ventricular pacing. And you can see that the pacing spikes are here. It's more obvious in some leads than others, but the shape of the QRS complexes here is identical all the way through. So we can assume that these are paced beats as well. Here, we've got pacing spikes without QRS complexes. So the pacemaker is firing, but it's not capturing the myocardium. It's not actually generating a ventricular contraction. So this pacemaker is malfunctioning. The only subtle thing that I would say, I think you'd say that you had a good stab at the rhythm. You certainly identified that there are more P waves than QRS complexes, but I wouldn't say that this is second degree AV block. I would say that this is complete AV block, because you can see here where the pacemaker isn't capturing that you've got multiple P waves that don't get through. Okay, so there's no relationship intrinsically between the P waves and the QRS complexes. The pacemaker is appropriately sensing the P waves and delivering a ventricular pacing spike, but the ventricular pacing spike isn't always capturing. So the underlying rhythm, I would say, rather than saying secondary, I'd say that this is underlying complete heart block. But otherwise, absolutely right. This is ventricular pacing, and the ventricular pacemaker isn't working all the time. So very good effort. Well done.
Charlie, can I ask a question? Why is it that some of the spikes are visible in some leads and not in other leads?
The same reason that QRS complexes look bigger in some leads than others. So here, the QRS complexes look pretty small. In other leads, the QRS complexes look pretty big. It's because of the axis. So depending on the electrode pair that you're choosing to look at, which is what each of these leads represents, sometimes the spike is going to look bigger if the energy is moving in the direction, so parallel to those leads. Sometimes the spike is going to look smaller if the direction in which that energy is moving is perpendicular to the direction of those leads. So sometimes it looks bigger, sometimes it looks smaller. That's there we go. Good question. Okay, moving on. I think, is this the last one? I think this is the last one. Yeah. What have we got here?
I can do this one.
Great. Okay.
I said that like every other QRS has a P wave, but I wasn't sure why.
Okay, good. Excellent starting point. Yeah.
And then I said it is negative in V1 and positive in the lateral leads, but I don't know if it's like wide enough to be bundle branch block.
Okay, great. So excellent starting point. So first of all, we've got two morphologies of QRS complexes. Okay, so which ones are we going to look at to decide if there's a bundle branch block?
V1 and V2?
So we're going to look at the beats which have got a P wave before them. So these beats, which are broad, not followed by a P wave, and very distinct, they're very different shapes to the ones that are preceded by a P wave. What do you think these beats are?
Oh, PVCs.
Yeah, these are PVCs. So we've got a PVC for every other beat, haven't we? So these are PVCs, and these are intrinsically conductive beats. So we're going to look at the beats which are preceded by a P wave. So the beats that are preceded by a P wave, these ones here, do we think that there's a bundle branch block here? We don't, because QRS complexes here are narrow. So these ones that are preceded by a P wave are narrow QRS complexes. It's the PVCs that are broad. So this is a great fooler here, because you might look at this and you might be asked to interpret the ECG, you might be asked to measure the QRS duration, you might be asked if there's a bundle branch block here, but these are not the beats that you should be looking at because these are PVCs, okay? So the intrinsically conducted beats, the ones that are preceded by a P wave, are narrow. These are sinus beats. There's no evidence of a bundle branch block here. It's just that there are an awful lot of PVCs and they represent a great fooler in this trace and one that you need to pay attention to, okay? So that's another tricky one. So I gave you some tough homework this week, but you guys have done really well. That's excellent work. Well done. All righty. Okay, so now we're going to start moving into some of the stuff that as a research group we're particularly interested in, which is today arrhythmia syndrome. So we're going to start out with this one, which is a personal favorite of mine, which is Brugada syndrome. So Brugada syndrome is a syndrome that predisposes to dangerous abnormal heart rhythms like this, or we've got polymorphic VT, torsade de pointe going on here. And it's associated with a characteristic ECG pattern, and it's that characteristic ECG pattern that we're going to be looking at. It may be inherited. It can be passed from parents down to children, and it's often, but not always, associated with the molecular reason is because it's just associated with problems with the way that heart cells bring sodium into the cells. These sodium channels are often dysfunctional in patients with Brugada syndrome. So, what is this ECG pattern and how do we identify it? So, The way you diagnose Brugada syndrome is so first of all, it's named the Brugada. It sounds like a funny name. It's because it's named after a Spanish a family of Spanish cardiologists, the Brugada brothers, and they described this syndrome where people die suddenly and they have this funny-looking ECG pattern. And this is the classic pattern. This is what was called a type 1 Brugada ECG pattern. And the key things to look at here, we're looking for this pattern in the right precordial leads. That means leads V1, V2, and V3. If you're seeing this pattern in other leads, that's not what we're after. We're looking for it occurring in these leads. And you're having at least one lead, which is showing this downsloping ST elevation pattern. It's a funny sort of pattern. You've clearly got ST elevation. Your J point, which is where the QRS complex meets the ST segment, is elevated, as is the ST segment itself, but it's downsloping. The ST elevation gets less the further away you get from the QRS complex. In this type 1 pattern, you also have T-wave inversion. So if you're going to be precise about the definitions for these things, there's got to be at least 2 millimeters, so 2 small squares worth of ST elevation in at least one lead from V1 to V3 that's downsloping and associated with T-wave inversion. Now, one of the tricky things about Brugada syndrome is that this ECG pattern may be there all the time, but sometimes it can come and go. Sometimes it can be revealed when people have a fever. Sometimes it can occur when patients are given certain sorts of medication, often medication that further influences that sodium channel. And sometimes there are unknown reasons why it can sort of come and go. But this ECG pattern can be dynamic. So this is the type 1 Brugada ECG pattern that you need to see if you're going to diagnose Brugada syndrome. There are other patterns that are associated with Brugada syndrome that are not fully diagnostic. Before we move on to that, this is a 12-lead ECG showing it. So if we look in lead V1, V2, we have this downsloping ST elevation followed by a negative T wave. So this is our Brugada pattern. We're not looking in the other leads for Brugada. We're looking in leads V1 to V3, and we've got this in at least one of V1 to V3. In fact, we've got it in 2 leads here, V1 and V2. Okay. On the other hand, we get other ECG patterns that are linked to Brugada syndrome, but are not fully diagnostic, and that's called the type 2 pattern. And again, you can see that these ECGs don't look normal. You've got a sort of an RSR pattern with ST elevation, but rather than that fully downsloping ST elevation, which then leads to a negative T wave, this has what's called a saddleback pattern. Okay, this saddled pattern here, where it sort of scoops like this before going up again into a positive T wave. So here, to be fully diagnostic of a type 2 pattern, the J point, again, needs to be 2 millimeters up, but the ST segment itself only needs to be at least 0.5 millimeter up. So here, in this case, we're 2 millimeters up for the J point, and we're about 1.5 millimeters up for the ST segment itself. Okay, and the T waves can be upright or they can be negative, but it's this scooped pattern here, this saddleback pattern here that you get in the ST segments. Okay. So that's a type 2 Brugada ECG, and this is what it looks like on a 12 lead. So again, we're not looking in the rest of the leads. Once again, we're concentrating leads V1 to V3. And here you can see that in V2, we've got this scooped pattern here. Here we've got a little bit of ST elevation here. Here in lead V1, you've got this downsloping ST elevation with T wave inversion. But it's not 2 millimeters, is it? It's barely 1 millimeter. So that's not diagnostic of a type 1 pattern, but it does look a bit odd. But we've clearly got a type 2 pattern here in leads V2 and V3. Okay, well, certainly in V2. So we've got a type 1 pattern and a type 2 pattern, and those are the key things to be identified when we're looking at some of these ECGs. And this Brugada ECG pattern can be seen in association with other inherited arrhythmia syndromes as well. We'll get these overlap patterns. So not all of you will be doing projects on Brugada, but you might be doing projects on, for example, ARVC. Sometimes ARVC can rarely be associated with some of these Brugada patterns as well, and so it's worthwhile. So it's important to be able to identify these things when you're interpreting ECGs. So we do our we normally do our ECGs in the standard positions every time, with our electrodes on the chest, with our electrodes on the limbs and our electrodes on the chest. But with Brugada syndrome, sometimes we put our ECG electrodes in different positions. We call these high precordial lead positions. So normally our ECGs wrap around the chest and we put them in specific positions, and normally the electrodes for V1 and V2 go in the fourth intercostal space, so the space between the ribs, so the space immediately below the fourth rib. Brugada syndrome it's easier to pick up Brugada syndrome if you put these leads a little higher, and we call these high precordial lead positions. So if you put them in the third or the second intercostal spaces, then you can increase your sensitivity for detecting a Brugada ECG pattern. So sometimes we'll record our ECGs like this, and everyone in different centers will print out their ECGs in slightly different ways. But here in Vancouver, we tend the way that our standard way of printing these out is that in the chest lead positions, it'll be high lead V1 and V2 in the V1 and V2 positions, high lead V3 and V4 in the V3 and V4 positions. And I've put this around the wrong way. Silly me, I've done this ECG wrong. I do apologize. There we go. And you can see that high V1 and high V6 are in the same positions as standard V1 and V2, and so they will go in these positions here. I'm sorry, I put V2 and V1. It should be the other way around. Oh well, silly me. So when you see any ECGs marked as high leads or high precordial leads, then this is what it's going to refer to, and they'll look slightly different, but they're there to increase the chances of identifying a Brugada pattern. So, for example, this is two ECGs recorded from the same patient. This is the ECG recorded in the standard leads, and this is with these V1, V2, and V3 here. And you can see that in the standard lead positions, there isn't any clear evidence of a type 1 or a type 2 Brugada pattern. Yeah, the ST segments look a little high here, but it doesn't have that characteristic scoop pattern. It's certainly not downsloping. There's no clear evidence for a Brugada pattern here. However, if we elevate the positions of those precordial leads and we put them in the high positions, we can then quite clearly see in the same patient that suddenly a Brugada type 1 Brugada pattern is now evident, and this is diagnostic of this is a type 1 Brugada pattern, and in the right context is diagnostic of Brugada syndrome. If you look closely, you remember how we talked about how high lead V5 and high lead V6 are in the same positions as V1, V2. That means if you look closely at this ECG, high V5 and high V6, high V1 looks identical to standard lead position V1 here. High V6 looks identical to standard lead V2 position here. Okay, so the high leads V5 and V6 are the same as standard leads V1, V2. It's all just brought up a little bit higher. Okay, and you can use this to increase your sensitivity for detecting Brugada syndrome. Second thing we can do is that we talked about how the Brugada pattern may vary in response to certain medications. So we can use that to our advantage, and we can use provocative testing. We can provoke a Brugada pattern in those who are susceptible to it by giving medications that influence the sodium channel. Here, we tend to use a drug called procainamide. In other countries, they may use another drug called agmaline. In other countries, they may use a drug called flecainide. But all of these drugs influence the sodium channel. The sodium currents. They block sodium currents, and they can provoke a Brugada pattern. If you do provoke a Brugada pattern like this, or if you've got someone with Brugada syndrome who's having lots of arrhythmias, then other drugs can decrease that pattern. And the drug that we tend to use for that in the acute setting is isoproterenol or isoprenaline, which is a drug that activates the adrenergic receptors, and it can suppress the Brugada pattern. Another one that can be used in the long term is one called quinidine. So here we've got an example from of someone at baseline having nothing much on the standard leads. There may be it's possible that there may be a suggestion of a type 2 pattern, but it's not particularly clear. But in the high leads, you can see that it's much more evident. When given procainamide, we develop a type 1 pattern also occurring in the standard leads, and that Brugada pattern becomes much more evident it becomes much more marked in those high leads. And then when given isoproterenol, it all disappears again. So the Brugada pattern can be influenced with drugs. And so when you're doing your research projects, you may see ECGs that have been performed during procainamide challenge, so during the administration of procainamide, and that's what this is all about. Procainamide being given to try and elicit a Brugada pattern. So here's another example. Baseline 12-lead ECG. Here we haven't really got an awful lot to go on here. The ST segments look a bit funny, a little bit fishy here, but it's certainly not diagnostic of a type 1 pattern. But when we give procainamide, in this case, we've got a clear type 1 pattern. So we've got more than 2 millimeters of ST elevation that's downsloping, followed by a negative T wave here present in V1 and V2, and probably in V3 as well. So we've clearly got a positive response here. Okay. There are other ECG features that might be associated with Brugada syndrome as well. So sodium, particularly in those who are found to have genetically proven sodium channel dysfunction, then these patients with Brugada may have conduction disease in other parts of the heart as well, affecting other parts of the heart as well. So in this case, we've got conduction disease affecting the AV node. And that's shown by the fact that our PR interval here is long. We've got first degree AV block. So if you remember, the PR interval should be less than 200 milliseconds, so less than one big square. And here, we're a bit beyond one big square here, aren't we? So we've got first degree AV block here in association with Brugada syndrome. Okay, so that's another key factor. So if you're doing a Brugada project, it's important to try and identify any conduction abnormalities that are present as well, particularly because those with conduction abnormalities may have a worse prognosis. And this conduction delay may be the only thing that is seen in family members of those who have Brugada syndrome. So this is a paper from a while ago talking about how the proband, the initial family members detected in a family may have a typical Brugada pattern, but in other family members, it may only manifest itself as a first degree AV block, for example. The other areas of the heart can be affected as well. So you can get conduction delay manifested as a prolonged QRS. Now, this doesn't necessarily, this may take the form of a typical bundle branch block pattern, a typical right bundle branch, a typical left bundle branch. But in some cases, it's just that the QRS it doesn't form a typical pattern because of one branch being taken out. It may be that the conduction is just generally slow everywhere, that the electrical signals are getting down through the His-Purkinje system, but it's just taking longer to get there. And so you may get this non-specific prolongation of the QRS complexes, so to out beyond 120 milliseconds, but not with a typical right bundle or a typical left bundle morphology. So this is someone at baseline who's got a slight first degree AV block, slight interventricular conduction delay. When you give them procainamide, then it becomes a much more obvious, it becomes a clear Brugada pattern there. But these things are also important to pick out when we're looking at these patients and their families. And this, unfortunately, this slide doesn't project particularly well, but in patients who do have Brugada syndrome, those who have broad QRS complexes, this interventricular conduction delay, and this may be associated with increased arrhythmic risk in Brugada syndrome. So there is a clinical relevance to identifying these things. So I guess the next thing to think about is, well, we're talking about ST elevation here, but how does that compare to ST elevation seen in other contexts, like the we did a whole session on myocardial infarction, didn't we? If we do a comparison here, if this is our Brugada pattern, we've got our down-sloping ST elevation. If in comparison, if we look at the ST elevation that you see in a myocardial infarction, it looks rather different. So here you've got ST elevation that's up, that could be flat, or in this case, even upsloping. And it's often convex upwards. There may be associated Q waves. And the main thing is, though, the presentation. So it's a little bit difficult if all you're asked to look at is an ECG. But one of the key things is talking to the person who's in front of you. So if someone's standing in front of you saying, yeah, I'm feeling pretty fine now, but unfortunately, I had a blackout, and I had a blackout a few weeks ago, which is a bit strange. And several family members all died at a young age, but otherwise I'm feeling pretty well. And this is what the ECG looks like. Then that's kind of suggested that there's a Brugada thing going on. Whereas if someone's standing in front of you saying, my chest feels like someone's sitting on top of it, it really hurts, I'm covered in sweat, and it looks like this, well, you've got to put these things in context, and that's much more likely to be a myocardial infarction. But anyway, you can see that if you put these two things side by side, you can see there is a difference between a Brugada pattern and the sort of ST elevation pattern that you get during a myocardial infarction. Downsloping versus upsloping or flat. Okay, so getting into examples. Oh dear, I've got a model here. I'm started jumping straight to example 2. I don't know why. All right, so anyone want to have a shout out? What do you think this ECG is showing?
Type 1 Brugada.
Yep, easy. Type 1 Brugada pattern. Yep. So we've got downsloping elevation in V1 and V2 and V3 with associated T wave. Type 1 Brugada pattern. Nice and easy. What about this one?
Would this be type 2 Brugada with the saddleback in V2?
Yeah, absolutely. Yep. So we've got a right bundle pattern, and then we've got type 2 Brugada pattern we've got right bundle branch block with a type 2 Brugada pattern with this saddle ST elevation seen here in V2. Excellent. Very good. What about this one? Does this look like a Brugada pattern?
Not from V1, V2.
No. So there isn't. So here, we've got a right bundle branch block pattern. So we've got an R, S, R prime. We don't have clear ST elevation here. We certainly don't have 2 mm J point elevation. So this is just a right bundle branch block. But this you wouldn't call this a Brugada pattern. What about this one?
Does it have Brugada 1 in V1 and Brugada, the saddleback in V2?
Okay, so this is good. This is good. Okay, so first of all, so I would agree that we've got T wave inversion here, and it is down sloping here. But one of the key criterion was how much of it there is. So is there 2 mm of ST elevation? there isn't 2 millimeters of ST elevation. So the J point is probably around here, and that isn't 2 millimeters up. So I agree it is downsloping, but this wouldn't fulfill the criteria for a type 1 pattern. However, in V2, we are elevated, and we have this saddleback, we have this scooped pattern here, don't we? So this is a type 2 pattern that's here, but that's a good shout out. But it's important that you need to have enough of it. You need to have at least 2 millimeters for it to count as a type 1 pattern. Okay, so that's a type 2 pattern that's there. What about this one?
It's an MI.
Yeah, excellent, very good. So this doesn't look like a Brugada pattern. There's clear ST elevation associated with Q waves here, but this is upsloping here. It's not downsloping. This is a pattern of a myocardial infarction. You can see that it's extending out as well. So very good, well done. No fooling you guys. Very good. So that's it for Brugada syndrome. A quick whistle stop tour. I will send round some. I'll send round some example ECGs for you to work on for the next session. And I was thinking maybe in in the next session we might do something about long QT. Sound okay?
Yeah.
Very good. Any questions?
Yes, I have a question. Between type 1 and type 2 Brugada, are there different genetic markers?
No, it's all the same genetic markers. It's a funny sort of condition because it's what we call having variable penetrance. It means that even that 2 family members having exactly the same genetic modification, genetic variant, might manifest either a very pronounced phenotype or a mild phenotype or no phenotype at all. And
okay.
It remains unclear for many people why that may be the case. It may be that there are modifier genes that are going on, so that although both family members may have the main primary causative gene, there may be modifier genes that vary between those 2 individuals. So it's the same genetic thing. It's just one is more pronounced than the other. And someone with a type 2 pattern will frequently, but not always, become a type 1 pattern if you give them something like procainamide.
Thank you,
Charlie. For one of the earlier slides when you were just introducing Brugada and you had those red dotted lines showing where the J point is. Just a question: isn't the J point where it becomes horizontal? How are we identifying the J point for Brugada syndrome where it just goes straight to a peak?
So that's a great question. So it's not where it becomes horizontal because there is no horizontal. So if you're going to talk about where it doesn't become horizontal until after the T wave. So the J point isn't where it becomes horizontal. It's where the QRS complex meets the ST segment, and that's a tricky sort of thing to determine frequently. In this case, you can see that there's a change in the angle between it's a relatively sharp downstroke here that then becomes a little shallower. And so that's where I've marked the J point here, but it can be difficult to tell exactly where the J point is. I agree that can be a tricky thing, but it doesn't have to be horizontal.
Okay, thank you.
And I have a question too. I guess, so for Brugada, you said like V1 to V3 are the ones that you would focus on.
Yep.
Would you expect to see, I guess, like reciprocal changes in the other leads, like kind of like MI? And and would you also see like Brugada pattern in other leads other than V1 to 3? And like, what would that mean if they were there?
Sure. So in general, you just for most patients, you just see it in V1 to V3, and you don't see any reciprocal changes like you would do in an MI. There, very occasionally, you will see it in the inferior leads in addition to the precordial leads. And if you're getting the inferior leads affected as well, then sometimes that can be that's been suggested as being a marker of a higher risk patient, someone a higher risk of arrhythmias. But if you just see it in the inferior leads and you don't see it in the precordial leads, then that's diagnostic. You might see it in addition to V1 to V3, but if you're not seeing it in V1 to V3, you don't call it Brugada.
Okay, thanks.
And sorry, Charlie, another question is, so sometimes your baseline, since it's so varying, how would you then determine for those types of ECGs whether or not you'll see a Brugada pattern or not, because you can't isolate what the baseline would be?
Yeah, that's a great question, and it can be really tricky there. So you've got to make your best guess at where the baseline is. You've got to, so you can try and draw a line along where your CP segment is. If it is moving up and down, then you've got to take your best guess at it. It may be that rather than being a flat line like this, it may be that the baseline may be sloped. If you can see that some are at different levels, but it may be the conclusion you arrive at is that you can't say whether or not there is. You can say this is a suspicious ECG, but the ECG needs to be repeated.
Okay. Thank you.
No worries. Very good. Very good. Well, thanks for coming on this morning. Sorry I was a bit late. And I'll send you that homework along, and I'll see you in a fortnight.
Thank
Thanks
you.
so much, Charlie.
Very good. Thanks a lot. Bye for now.